Good afternoon, everyone. We now move on to the second symposium for the day, Regional Perspectives on Emerging Ethical Issues. I'm Aishwarya, a pediatrician from NUH, and together with Professor Sarah Abraham, will be a chairperson for this symposium. So we have today for this symposium 5 very excellent talks lined up from speakers across the region. After the talks, there would be time for a panel discussion as well. So our first speaker for today is Professor Mora Claramita, who is the head of Department of Medical Education and Bioethics, Faculty of Medicine, Public Health and Nursing at Universitas Gadjah, Mada. Her studies include health provider-patient relationship and teacher-student relationship, and she is an active family medicine doctor as well. She is also the current chair of the Indonesian College of Health Professions Education and the chair of the Indonesian Society of Teachers in Family Medicine. Professor Claramita, please.
Thank you very much, Professor Roy and the committee, to invite me to this conference. So, continuing to the talk that we just discussed, this is a perspective from Indonesia, or maybe Southeast Asia, or maybe Asian countries, and maybe, I think, the other countries as well. So the title of this presentation is The Yes Doctor May Not Always Agreement, and it's about informed and shared decision making. So there was a case to be reflected later. The case was from my teacher. She's a pediatrician in Gadjah Mada University. And when she was graduate as a pediatrician, she felt very guilty that one of her baby patients died from a diarrhea with a severe dehydration. So the pediatrician said that I already provided all information needed for the mother, including what to do with the oral rehydration therapy, how to seek help, how to call me at any time. And all she said was, yes, doctor, and yes, doctor. I thought she understood, but she did not. And the case, should I? Yeah. So I make this video. It may be representing or not the scenario, but it's just made like one day before I came here, just to illustrate.
Dok. Ya, pagi Ibu. Silakan duduk. Ya, makasih Dok. Ibu dengan Ibu siapa?
Saya Bu Siti, Dok.
Ibu Siti.
Iya.
Ini anaknya kenapa Ibu?
Semalam itu diare terus. Ya, terus saya minumi asid, tapi muntah terus. Terus itu gimana ya Dok ya bagusnya?
Sudah coba dikasih obat?
Belum apa-apa.
Ya, ini Ibu, tadi saya sudah tanya-tanya, terus juga sudah saya periksa anaknya ya. Memang kondisinya sekarang itu anaknya lagi lemas, karena kan cairannya keluar lewat buang air besar yang lebih sering dan juga muntah tersebut. Tapi kalau misalnya kita kategorikan sekarang belum masuk ke dehidrasi, sehingga nanti masih bisa dirawat di rumah, nggak perlu ke rumah sakit. Tapi ya itu ya Bu, nanti kan saya kasih obat namanya oralit. Nah, oralitnya itu harus diminum sampai habis ya, sedikit-sedikit. Karena kalau tidak nanti kondisinya semakin parah. Nah, nanti kalau misalnya anaknya semakin lemas, nggak mau sama sekali minum, Ibu harus segera ke rumah sakit ya Bu. Atau telepon saya.
Ya Dok. Ya Dok. Ya, makasih ya Dok ya. Ini buruan mau jualan Dok.
Oh iya.
Makasih.
Iya Ibu.
And how to come back. So perhaps you noticed, thank you. Brief reflections on the role play. So what did you see, like, on the patients, on the parents? Yeah, try to text or scroll the phone, and then? Distracted. She's nodding, but seems doesn't understand perhaps. And do you see that she carry a lot of things? So in the morning, actually, she has to sell the nasi kuning at 7 o'clock. So she has diarrhea child, but she has to sell at the pasar. So, it's and she just say yes and nodding, but the doctor may not so aware of the conditions of the mother at that morning. Although she carried the children to the child to the doctor, but she has something else in mind. So these are the evidences. There is fundamental resources of cultural dimensions made by Professor Geert Hofstede from Maastricht University, and you can scroll the Geert Hofstede compare countries. There are 6 cultural dimensions. The first one is the power distance. So the acceptance between the people in the society, acceptance of different social gap. So like a teacher and student and parents and the children and also doctor and the patients, or health professions and the patient, or men and women. And the second one is individualism versus collectivism, which means the differences in making decision, whether this is has to be made by individual or can be influenced by the family, relatives, parents, and etc. And then the third one is masculinity versus femininity. It means the gender, so the authority between the man and the woman, and the rest of the dimensions you can scroll it in the website of Professor Geert Hofstede. So actually we can play the compare countries in the Hofstede insights, and although I know that Indonesia and Singapore has so many differences because you are a developed country and we are still developing, but actually we are similar in terms of power distance. And this is not only Indonesia and Singapore, I think Indonesia and many other ASEAN countries. And I also found in Latin America, in Africa, and Mediterranean. So the first dimension is the power distance. Indonesia and Singapore, we have a very high gap, social gap between people, and we accept that. But for United States, for example, they are more egalitarian, more partnership in relationship. And for the individualism, collectivism, actually Indonesian and Singaporean is also similar. We take influence of other family member and relatives into the decision making, but for the US, they have to be independent and responsible for the individual. So, and we also can learn from this book from Erin Meyer, The Cultural Map. You can Google that, and I think we all already saw the film Crazy Rich Asian, which definitely the patients wants to direct their children what to do. And Emily in Paris representing, although they are coming from the same, like France and the United States, but there are also still many differences in the cultural gaps. And this is my study like more than 1 decade ago, but I think still relevant today. So when I asked the patient, the medical students, and the doctors, and the setting was in the internal medicine department, the first question is, what do you want, how do you want the doctor-patient consultation be ideal? And then all of their answers, they say that we want trust, equity, and two-way exchange information. So it was amazing that in a very hierarchical, paternalistic society, they can say that we want trust, equity, and two-way exchange information. And then the second question I asked to the doctor, so can you do that ideal style of communication? And then they say, no, we cannot do that. Why not? Because we don't have time. There are a lot of patients. Every day we take care of like 100 patients. There is no patient appointment at that time. Okay, and then the third question we asked to the doctor. So for example, if you have time, like in the ward, or when you visit the patient at home, or you have a patient in the clinic, in the private clinic, can you do the ideal consultation with the patient? And then the doctors say, no, we cannot do that. Why? Because the patient is not prepared for participatory consultation, because simply a lot of patients in Indonesia, they doesn't have a higher educational background. And then the last question we asked to the doctor, okay, now you have a bachelor degree or master degree or PhD degree patient, and you have all the time you need. Can you do the ideal consultation with the patient? And then the doctor started to think, I cannot do that. Why not? Because I do not know how to do. So it means lack of training on communication. And then we redo the study. We did a grounded theory methodology study. We asked with in-depth interview, and the sample was like 100 or more sample. We want to know what was desired by the doctors and by the patients. And by this publication, we know that actually these are two diagram fan which is not match each other, so it's very separated. And the patient, they desire closer relationship with the doctor, but not the clinician. So the clinician maintaining the hierarchical and the social distance. They say that I'm the guru and I know more than the patient. However, trying to understand the doctors that they grew up in the society since their childhood until they're being medical students and then residents, and then when they do their clinical consultation with the patient, it's difficult for the people in this society to do a more partnership communication skills. However, this is a very recent study, just last year, and this year published. We asked the clinical teachers, and the students, what do you think about our curriculum in medical education? Is there any problem? And then they answer with, yes, we have a lack of constructive feedback. So again, 10 years later, with a different study, the society, which is still very hierarchical, can express the opinion that here in this context, we have a lack of constructive feedback. And there is a cognitive overload in the curriculum, and so the teacher-centered learning is still dominant in the curriculum. And then we ask the second question, so do you have any opinion to make the curriculum better? And then they started to answer that, yes, we need a guideline of giving constructive feedback, more formative assessment, more partnership relationship between the teacher and the students, and more professionalism training and guide. And the practice of one-way feedback also proven in this study of my colleagues and my PhD students in the scoping review study and also ethnographic study. And then I remember there's a Professor Arthur Kleiman from Harvard University. So he was married with a Chinese woman background, Chinese background, I think. And in this book, he said that he was so amazed with the Chinese that there is a patient in the family which is very ill, terminally ill patient. He knows, and every member in the family knows, but they do not talk about the problem. And it's very different with the US when they talk about the problem and how to support the patient and the family. So Professor Kleiman published like 8 questions how to guide the health professions in exploring the patient perspective. Like, what do you call your problem? What do you think has caused it? Why did it start? And do you think this is long or shorter period? And what do you expect? What do you fear most? And there is a UK curriculum wheel which I think underline the foundation of thinking and attitude. So before we can communicate with others, it's very important that we respect people. So then comes from the respect, there is a verbal and non-verbal communication comes with it. And these are the guidelines that I and my students trying to sorry, is it? Yeah, so trying to develop in order to approach the more partnership communication. So there is a grid invite discuss guideline for the doctor-patient communication, the PRIMA guideline, the provision report, information exchange and advocacy for the pharmacist-patient communication, and the trio guides for interprofessional communications. So O is open collaborations, open for exchange information, and open for discussion. And these are guidelines for my students. Dr. Sylvia developed a trust model for teacher-student communication in clinical education, and the caring model for family doctor-patient in helping the adolescents to understand that they have diabetes mellitus type 1. So the case was told by Professor Yati Sunarto, and then she concluded that the only cues to save lives may be the nonverbal signs of the patient or the parents, and we should always pay close attention to that. And all of this story was summarized in the book and also my publication. The key is to having mutual dialogue. Thank you very much.